Good afternoon, everybody, and welcome to the final session of the Northern Cancer Alliance Learning Event Week. Can I just begin by thanking you all the delegates and all of our presenters this afternoon and the presenters from the rest of the week for coming along to the event and being part of all of the different sessions. We greatly appreciate the time that people have been able to give us, particularly in the current climate. So without further ado, I would like to introduce our Northern Cancer Alliance Chair, Mr. Andrew Welsh. Thank you.
Well, thanks very much, and welcome everybody to the meeting. I must admit it's a nice relief from the COVID and vaccine frenzy that we're going through in the trusts at the moment. But we're delighted to say that there's a light at the end of that very long tunnel. So let's enjoy this afternoon. We've got some great presentations this afternoon to finish off the week, and I'm sure we'll appreciate the time that's gone into preparing these and also coming to talk to us this afternoon. So firstly, we have Professor Peter Johnson, who's the National Director for Cancer, who is going to talk about the future view for cancer, including transformational aspects of long-term plan in the light of COVID-19 and all the other aspects relating to personalised medicine, genomics, etc. And following Peter will be Alice Simon, who's the Senior Programme Manager for the Quality of Life for the National Cancer Team, who will be talking about the rollout of the National Quality of Life Patient Survey. And then followed by Dan Carrard, who's Deputy Director of Operations of the National Cancer Team, talking about implementation of the rapid diagnosis centres and community hubs. So if we've got time at the end, we'll have some questions. Obviously, that's entirely time dependent. So for the actual, so that this meeting flows effectively, I think Katie Elliott is going to introduce and take over. They do the sort of intermediate act, if you like, and then I'll be here at the end to sum up. So Peter, welcome to. I would normally say welcome to the Northeast, but welcome to the Northeast virtually. Over to you.
Thank you very much, Andy, for the welcome. I'm going to talk briefly this afternoon, firstly, a bit about what's happened to us all over the last few months and where we've got to in our thinking about that, and then do a little bit of future gazing about some of the things that you'll have been hearing about in the news, about some of the plans we've got, particularly about how we're hoping to get closer to our early diagnosis target by some new technology. Can I have the next slide, please? Thanks very much. So you will all remember this is where we were about a year ago, and this is what we were talking about. We were talking about where we were going with our implementation of the long-term plan, and this was the slide I was using at the tail end of last year, talking about making sure that we rolled out our screening program, and in particular that we got the targeted lung health checks up and running and all the pilot sites screening patients. We were talking about improving access to diagnostic tests and making sure that we had the full range of diagnostic capability, particularly things like endoscopy and scanning. That we were making progress with things like precision radiotherapy with SABRE, and all the newest forms of treatment, that we were revising our follow-up to make sure that our numbers of hospital attendances for people following treatment were kept to a minimum, and that we were delivering the appropriate personalised care and remote follow-up where that was appropriate, and that we were working with all our partners in academia and industry to develop things. Well, that was a plan. Next slide, please. And of course we had all our priorities that we'd shared with you all at the same time, which was particularly to make sure we were delivering the waiting time standards, that we were driving down the time to diagnosis, that we were implementing time pathways for things like esophagogastric cancer, which is very much on our target list, that we were, as I say, making progress on screening and early diagnosis, particularly making sure that we optimise the uptake of the existing screening programmes, that we were getting the right rapid diagnostic centres going and doing the lung health checks, and as I say, that we were doing the appropriate follow-up, and that we were stratifying some of the big number cancers so that we could free up space at the front end of the pathway. Well, the best laid plans and everything. Next slide, please. This is what happened to us, and all of you know this as well as I do. The information on the left is management data, so that's not published, but it's a bit out of date anyway now. But it essentially gives you the picture, which is what we saw. That this is our 2-week wait referral numbers that went right down to a quarter of their usual value in Easter week, and have been slowly coming back up since then. And I'm glad to say that thanks to a huge amount of hard work on the part of everybody out in Cancer Alliances and colleagues in primary care, that our 2-week wait referrals are now back to where they should be. And alongside that, of course, we had a huge drop off in diagnostic activity, and the graph on the right there shows you what happened to the volumes of colonoscopies being carried out in England, where we started out in March at about 74% of our normal, just as the lockdown was starting, and then plunged down to under 10% of the usual amounts of colonoscopy in April, and have been slowly recovering since that time. And again, that data stops in September, but I'm glad to say that we're now almost at normal levels of colonoscopy, and have caught up. But again, that's been a huge struggle, big concerns about the infection control, and the limitations in capacity, and a lot of hard work by a lot of people up and down the country to make sure that those services have been turned back on, because of course that's absolutely critical to lower GI cancer diagnosis, colorectal cancer diagnosis. Next slide, please. So in terms of putting services back on track following the huge disruption of the pandemic, the 3 key priorities we've set out, and again these have been widely discussed with you, was firstly to make sure that we were getting our referrals back to the levels that we were seeing before the pandemic. We have seen a big drop off in the numbers of people coming through, and we wanted to make sure that we were catching those up as quickly as possible. Secondly, of course, and this has been a big focus, we saw a big disruption to diagnostic pathways during the worst part of the pandemic, and we saw a jump in the numbers of people who were waiting on diagnostic pathways following an urgent referral, and increasing numbers of people going past 62 days. So we wanted to prioritise catching up with the longer waiters, recognising that if we did so, that wouldn't help our 62-day performance, because of course those people had already gone past it, but we felt it was important to make sure that people had the priority to bring patients through on the basis of their clinical urgency, rather than just trying to get the percentages right on a spreadsheet. So and again, everybody's done a lot of work to make sure that our very long waiters over 102 days have been steadily coming down since the peak that we hit in the summer. And finally, of course, to make sure that we have the capacity to deal with the pent-up demand in the system that we anticipated from the people that we'd not previously seen, and to make sure that we were doing everything we could to adjust our diagnostic pathways to make sure that we had the capacity to look after the people that were going to come back into the system who we hadn't seen over the pause during the summer. Next slide, please. So thanks to everybody's efforts, I think we have done very well. The graph on the right here shows the numbers of patients that have come into the system that have been actually seen following an urgent referral, and you can see that by September we were at 102% of our normal levels of activity, with about 200,000, and that rise has carried on. We're indeed at 100% or slightly more in most places. It's been different in different parts of the country, and I think it's probably been more difficult in your neck of the woods as it was in the northwest, because of course coronavirus, the second wave, hit that much harder, and was caused a further disruption to the system. But in general terms, I think everybody's hard work has really paid off. And we know this is incredibly important to the people that we look after. And furthermore, that in September, of the over 1 million people who were referred between March and September, more than 90% of them were seen within the 2-week interval. And of course, you will have seen, and thanks for supporting the public messaging, the Help Us to Help You campaign, which we started out in September with sort of generic cancer symptoms, weight loss, bleeding, lumps, and so forth, and then have focused more recently in the campaign that started in November on abdominal symptoms in particular, because we know that GI cancer, gynae cancer, kidney cancer, which are covered by that campaign, had been ones that have been particularly badly hit in terms of referral numbers. And I'm glad to say that the early feedback from those campaigns has been very positive. They've also been carefully targeted at the groups that we often find it harder to reach, the less well-off groups in society, older patients, and people from Black and ethnic minority groups. And there's been a lot of very specific targeting of the media, for example, a lot of use of community radio to try and make sure that we are getting to the groups that were worst affected by the downturn, to make sure that we're really getting the message out there and that we're helping people to understand that the NHS is there for them, in spite of all the disruption and chaos that we've seen as a result of the pandemic. Next slide, please. And so, as in parallel to the referral levels coming back up again, so have the levels of treatment. And again, the graph on the top right there shows you the number of first treatments on the 31-day pathway. So that captures urgent referrals, referrals through screening, and referrals through other pathways as well. And you can see that, in fact, the dip in that was never as bad as we saw in the numbers of referrals. It went down to about 2/3 of normal in May and has been steadily back up. And again, since September, has continued to rise and is now at least the level we would normally expect. So that again reflects a huge amount of hard work. And we did a lot of adapting, and again, you'll be aware of this, that for example, radiotherapy, we were able to reduce the number of fractions post-operative radiotherapy for breast cancer. It was good fortune that we had a trial that came out that showed that was just as effective to give a small number of fractions as a much more prolonged course of treatment. So we were able to do that very quickly, helped of course by moving to a block contract, which took away the perverse incentive of people getting paid per fraction. And we also worked very well with NICE and with the Cancer Drugs Fund to make sure that we could roll out as quickly as possible changes to the recommendations for systemic anti-cancer treatment to allow people to have more oral agents, more immunotherapy instead of conventional chemotherapy, and treatments that would allow them to spend less time coming to hospital and having less visits where they might be at risk of picking up infection. And again, I'll show you a bit of data on that in a sec. That's been very successful at not only maintaining, but actually increasing the uptake of some of the newer cancer treatments. At the bottom there, it shows you the difference according to the different tumour types about the levels of activity that we've seen. And you can see that actually all of them around the 80 to 90% mark. Urology is particularly low, the last one from the right, last but one from the right, mainly because less people have been going and getting their PSA levels measured in GPs. So we haven't seen the people with prostate cancer who don't have symptoms in nearly the same numbers, and those have been not coming through. Breast cancer has been affected mainly by the hiatus in the screening programs, so not nearly so many mammography invitations being sent out, and so we've not seen so many ladies with early stage breast lumps. Some compensation with people coming through the symptomatic referral pathway. We've seen large numbers of those certainly in the last couple of months coming through. And you can see that GI cancer similarly has been a bit pushed down, and again that's mainly reflects the numbers of referrals. As I say, the hard work on longer wait has meant that we've made good progress on bringing down the number of people waiting over 62 days, so that we're very nearly back to the position we were at this time last year in terms of the numbers waiting. We know that we still have some way to go, and before the coronavirus ever started, we knew that we had issues with our 62-day performance and needing to help people to get diagnosed faster, but it's at least something that we're back to where we were before all this happened. And again, I think this reflects a huge effort on everybody's part to make sure that cancer diagnostics and cancer treatments were being prioritised. Can I have the next slide, please? So this is our overarching plan on a page, which again has come around, and I'm not going to go into in huge detail. The priorities across the top I've already referred to: restoring the referrals, the public information campaigns, making sure that we can streamline the process from primary to secondary care, making sure we're driving down the numbers of long waiters, and a lot more visibility of the data on that to make sure that we're reporting that in an almost real-time basis, and making sure that we maximise our capacity. And again, you'll have seen a lot of information come round about ways of streamlining the diagnostic pathways to make sure that we take advantage of things like straight to test wherever possible, triaging according to fecal immunochemical testing for lower GI symptoms, in order to make sure that we're prioritising the right people for scarce colonoscopy resources and so forth. And I think again that's been very successful, and we've seen, for example, the early returns from the colonoscopy data suggest that we're picking up more cancers per colonoscopy than we were previously, which suggests that people have got clever at how they prioritize the people who are going to get colonoscopies, using things like FIT in order to select the people who are at highest risk. So obviously this, and I'm not going to go in huge detail through the how of all this, to say obviously that our colleagues in the alliances have been massively influential and effective in getting the system to do what we need to do, with making the links with the providers and making sure that the mutual aid schemes and the surgical hubs and such like are functioning as well as they can be, given some of the local geographical considerations and so forth. But I think it has been throughout the coronavirus period a really good demonstration of how effective our alliance system is at helping us to get messages out, helping us to gather information about what's happening, and making sure that local systems are really doing the maximum to deliver care in the most difficult circumstances any of us have ever experienced. The inequalities, as I say, we are very much alive to, and you will have seen yesterday we published some data about the effects of the downturn, the coronavirus downturn on different groups according to deprivation and ethnicity, which, as we might have expected, were worse in more deprived and less well-off communities, but have leveled up again as the recovery has taken place, which is very encouraging. We've obviously done a huge amount of work trying to promote public confidence, and again a lot of the public-facing campaigns, and also doing things like implementing coronavirus protected environments, using asymptomatic testing where we could, to cover both staff and patients. I'll talk a little bit more about the innovations and where we're going with those in a moment. The workforce again is clearly an issue. It was an issue before coronavirus came along, and having more people self-isolating, off sick, and not able to work for a variety of reasons has put even more of a spotlight on the fact that we really need to expand our workforce, to upskill our workforce. And we have, as a result of this year's spending review, more money coming through, certainly to do training for particularly specialist nurse roles such as chemotherapy giving and clinical nurse specialists, and we're in active discussion, I should say, about what else we can do to expand our workforce, because that feels absolutely critical to delivering for the future. You're going to hear a bit from Dan in a minute about the rapid diagnostic centres, which was one of our long-term plan priorities for helping us with recovery, apart from anything else. And we thought very hard, very quickly, as coronavirus hit us, which bits of the long-term plan do we really need to continue prioritising to get us out of the situation that we're in with coronavirus, as well as supporting what we were going to do anyway. And rapid diagnostic centres is certainly one of those, as were our targeted lung health checks, because we could see the effect that the coronavirus was going to have on referrals with suspected lung cancer, and the huge reduction in the numbers of chest x-rays being done in primary care, which happened very quickly. And so we've been trying to get the lung health checks reinvigorated as quickly as we possibly can. I'm glad to say that I think 9 out of our 14 sites are now up and scanning patients, and we're pressing ahead as fast as we can with all of them. And the other thing I think we've learned in this process is how we can communicate differently. And as you know, we've been having twice weekly alliance calls, and I've been meeting with also with oncology centres up and down the country. It was on a weekly basis, it's now fortnightly, and also working with charities on a very regular basis, and that's been enormously helpful. And this huge expansion of remote working and video conferencing, I think, has been hugely beneficial in getting much broader inputs and a much more ready form of communication. So I think we are going to continue doing this in the future, probably not at the intensity we're doing it at the moment, but certainly on a much more regular basis. Next slide, please. So what have we learned through all this process, and what takeaways are there for what we do next? Well, firstly, I think the resilience in the system and the ways in which we've coped and the ways in which the cancer service has coped is a real reflection of how effective the collaboration was in localities. And this was between providers. Alliances were the fantastic brokers of many of these relationships, between NHS providers and private providers, and indeed across national organisations. And spending our time on these video calls, I think, has been very helpful for helping people to learn from what's worked well in other places. We've made some rapid innovations in care. Obviously, infection control and the separation of coronavirus protected pathways has been a very important part of what we've done. And it's highlighted for us some of the imperatives, particularly in diagnostics, which we'd been talking about before. And obviously, Mike Richards' review of diagnostics has drawn on this information. We had a clear sense before all this happened that taking elective diagnostics, as you might call them, away from acute sites to try and protect them from the pressures the service pressures that you get might be something that we would need to consider doing. But I think the infection control issues that we've seen with coronavirus have just reinforced that argument. So the drive to set up diagnostic hubs that are somewhat distinct from acute hospitals is something that we're going to need to do more of, and clearly that the speed at which we make progress on that is going to depend on how the results of the spending review come down. But I think there's no doubt that we are going to be doing different things in diagnostic pathways in the future, and many of the innovations that we've put in place certainly are going to be here to stay. The little picture of the pill cam is our a reference to our colon capsule endoscopy pilot, which again is rolling out across the alliances and starting in the new year. And the idea here is to offer this as an alternative to conventional colonoscopy. This is a pill that you swallow that goes through the gastrointestinal tract, taking pictures as it goes through. A little disposable miniature camera, which is linked to a recording device that you wear like on a belt. And this is an alternative to conventional colonoscopy, and we're going to pilot that in a group of people with a not entirely negative but low-level FIT score that are coming with for referrals for lower GI symptoms. And we think that this will help us to take off between 10 and 15% of the people on the colonoscopy waiting list. So it's not a solution to the problem, but it's potentially quite a big contribution to it. So that's starting up. Our ability to respond to research findings, I think, has certainly accelerated, and things like the introduction of the hypofractionated radiotherapy is a case in point. And the graph in the middle there is from a paper that we published in the Lancet Oncology about the uptake of new cancer drugs. These are the Cancer Drugs Fund drugs that are on the BlueTech system. And what you can see there is different categories of drug. The left-hand end is for all the drugs, and you can see the pink bars. In April we saw quite a big drop in that, and then by May it was coming back up, and in June it had gone up to greater than previous use. And the next one in is for curative treatment, and you can see there's been a huge jump in the uptake of curative treatment drugs in May and June. Some of the others have stayed lower, things like neoadjuvant treatment, which has largely been held back, and people have been going straight to surgery rather than having that. But overall, I think this has been a great way of adapting and very rapidly adapting the way we treat people. The graph at the bottom is the risk model, which was derived by the academic general practice unit in Oxford, looking at what had happened to people drawing on NHS data systems during the peak of coronavirus and relating that to what sorts of treatment they were having. And so this is an expression of the relative risk of dying from coronavirus. I think this is for women. They broke it down by gender, but this is for women. And what you can see, we graded chemotherapies, systemic anti-cancer treatments, into 3 levels of intensity, sort of low, medium and high. And you can see that the hazard ratios, the risk of dying of coronavirus, go from 2.3 times more likely than the normal population up to 17 times more likely if you have very intensive chemotherapy. So that's really useful data for us to talk to patients about the risk-benefit ratio of different types of treatment and how much additional risk these things convey. And you can see other things like having a blood cancer, a hematological malignancy, having had a stem cell transplant, having had a lung cancer. All of these add somewhat to the risk, and you can see that these are all different. And there's a whole table in that paper in the British Medical Journal which helps us to individualize people's risk profile. And I think that has been very helpful, and the levels of communication and sharing of information like this, I think, have been enormously helpful, and as I say, things that we're going to carry on doing. Have the next slide, please. This is a little bit of looking ahead to the future, and in particular, you might have heard on the news the announcement about the partnership between NHS England and this company Grail from the United States. Obviously, one of our key targets for the long-term plan is to move early diagnosis from the current 54–55% of people being diagnosed at stage 1 and 2 up to 75% before the end of this decade. And that's a very stretching ambition, given that the rate of improvement has only been about 1% per few years up until now. And that really means that we're going to have to find different ways of discovering people with cancer at a much earlier stage, probably before they have symptoms, because there's only so much we're going to be able to do with encouraging people with symptoms to come forward. So we've been looking around for what other technologies out there, and this is one that we think may have some promise and which we're planning to test. So the Grail company take blood from people, and they look at chemical changes on DNA, which is shed from tumours at an early stage into the circulation. So we can pick up these minute amounts of DNA going around in the bloodstream, which for the chemists in the audience have got methyl groups on them, these little CH3 groups. And the pattern in which those are added to the DNA, which is something which happens early during cancer development, varies according to where in the body the cancer is growing. So the pattern you see on a colorectal cancer is different to the pattern you see on a pancreatic cancer or a head and neck cancer. So not only does the blood test tell you there's a cancer developing somewhere potentially, but it also tells you where to go and look, which is obviously very important. Otherwise we end up testing a lot of people for things that we don't know where we're supposed to be looking. Now, at the moment, the information that's been published, and I put a link to the paper on the slide here if people are interested, is only from people who have already been found to have cancer at different stages, where they took the blood when they'd already been found to have cancer. And the question then is, can we use this to look in healthy people to see if, for people who are at risk of developing cancer, if we can pick it up at an early stage as a screening test? And one of the important points about this test is it's very, very unusual to pick up these changes in the DNA in people who don't have cancer. The specificity, so-called, the likelihood of it being that there is a cancer somewhere if you pick up a result is a bit over 99%. So it's a very good test at saying if it's positive, there's probably something going on. What we don't know is how sensitive it is. That's to say, what proportion of cancers that are developing it actually picks up if you look in the blood. Have the next slide, please. So this is the data modelled by Grail. And so it's all been done by them on what they think they might do with the sort of cancers that it's best at detecting that occur in the sort of numbers we see them in the UK in a group of people between the age of 50 and 80, if we took blood from them every year for 3 years to see if we could detect cancer. And what you can see on the graph there are what's currently happening. So our current standard of diagnosis, you can see that there's quite a lot of people diagnosed at stage 1 in the left-hand column in the grey bar, and then it goes down through 2 and 3, and then there's a higher number that we diagnose in stage 4. and using the way that the test works in the data that they've got so far, the purple bars show what they're expecting to be able to show with 3 annual rounds of screening in the blood. So a big reduction, as you can see, in patients with stage 4 to about 1/3 of the current numbers, and correspondingly a big jump in the numbers that we're picking up in particular at stage 1 and 2, from 57% to about 77%. So that would be massive if that works, and it is of course a big if. Next slide, please. So this is the and I have to say this is a work in progress. This is not a fully finalized design. We're in very intense discussions with Grail about how this should be done, and they are contracting with one of the trials units in the UK, which is particularly good at big population epidemiology studies. They've been involved with things like cervical cancer screening trials and things in the past, so we're confident that they're the right people for the job. But the idea would be that Grail would invite 140,000 people aged between 50 and 77 to have a blood test taken, and the plan would be that they would organise to do this so as not to put a big burden on our colleagues in primary care being asked to take blood. So they would identify people from the NHS digital systems and invite them directly, and then half of those people would have blood taken but stored and not immediately tested, and the half of them would have the blood test taken and the results returned to them. And in those people where there was a signal picked up, and the numbers are relatively small because of course these are people with no symptoms at all, so it's a few thousand cancers that we'd expect to pick up in this way, that we would then have them come into the 2-week wait referral system, either to the appropriate tumour specific pathway, because that's what the blood test tells us which pathway they should be on, or if there was any doubt, then we would have them come to one of our rapid diagnostic centres for non-specific symptoms. And the idea then is to see whether the pickup in that group of patients of early stage cancers is different to the control group where the test results aren't sent back. And the targets for doing this, as I say, are a reduction in the numbers of people with presenting at stage 3 and 4, and at the same time an increase in the proportion that are diagnosed at stage 1 and 2, with the positive predictive value of the test being at least 30%. And to put that in context, the positive predictive value of something like a mammogram is about 10%. So this would be a good test in screening terms. So that's very much a work in progress, and I'm, to be honest, we don't know whether this will work, but it feels like the sort of thing that we should be doing. And what's exciting is that this company, which is a big US-based company, they come from a company which specialises in making sequencing equipment called Illumina, have come to the NHS because they think we can do this, and they come to the NHS rather than go anywhere else in the world because they know what you're all capable of in terms of organisation and our pathways of care. So that's a real boost for what the NHS can do, and I think it goes in parallel to things like being able to deliver the vaccine for COVID faster than anywhere else in the world. I think there is a recognition that this is stuff that when we put our minds to it, we can be really good at, and I'm very excited to see the results. So I will stop there. I think I'm probably out of time, and I think I'm out of slides as well, and take any questions. Thank you.
Thank you, Peter. That's fantastic. And I'll just go to Joe. We got some questions there from our delegates.
Yes, we've got quite a few questions. So what I'll do is I'll start with the ones with the highest number of likes. So we've got high level of triage telephone consultation with a consultant has been so important in directing people to the right test. Why can't this be counted as a first contact for suspected cancer referrals as we move towards 28 days? FDS being the most important standard, this is the way that this work can be properly recognised in job plans.
I have a lot of sympathy for that, and I think we are trying to adapt the rules and regulations, and Dan is probably more of an expert than I am on exactly what gets counted. As far as I'm concerned, I think if people have a telephone consultation with a consultant as part of their 2-week wait referral, and they are started on the diagnostic pathway, and a proper history is taken and so forth, that can count as the first contact as far as I'm concerned. And whilst I continue to see patients in person, sometimes I'll have a telephone consultation with them one week, let them know what we know about the situation and book some tests, and then arrange to see them in person the next week. But I think there are different ways of doing it, and people's individual clinical circumstances will dictate differently. But as far as I'm concerned, I think we should be moving towards allowing that. Inevitably, a lot of consultations still need to be face-to-face, but it's a meaningful medical contact if you're going through the medical history and planning tests, so I don't see why not.
Thank you, Professor Johnson. The next one is, how can the Mike Richards report support not just recovery from COVID, but increase access to diagnostics?
Yeah, I mean, Mike's report is really all about diagnostic capacity and how we go about increasing it. So it's about more kit, it's about more people, and it's about a different using our workforce more effectively as well, so that we're getting things done at the right level. More reporting radiographers, for example, as a means for dealing with some of the high volume work. And of course, there is this model of the community diagnostic hub, which is intended as an addition to, not a replacement for, the diagnostic capacity that we already have. Now, what remains to be seen, as I've said, is how much money there's going to be in the budget to implement that. But we see that as very much aligned with what we're already trying to do with rapid diagnostic centres. And if we start to see community diagnostic hubs being set up, if there's the money to do that, then we think that will be massively helpful for our RDC pathways, because I hope it will give us extra capacity. But of course, there's the big question is how much of that will we be able to get, and how much will we be able to expand the workforce, because that's clearly a critical determinant of our capacity.
Thank you. And the next question is, trusts are always looking at new ways of working to manage workforce shortages. How can the national team influence the number of trainee oncologists in the system?
I'm glad you asked. I'm doing everything I can, is the answer, and we've been in intense discussions with Health Education England about how they use the money that's been allocated to them in the spending review. I'm pretty sure that is going to be a continuing and ongoing discussion as we go forward. As people will know, the spending review has only given 1 year's settlement at the moment, which is complicated if you're Health Education England and you're trying to organise 5-year training plans for people, and how to increase those numbers and being able to have confidence that you can continue increasing them. But it is vitally important that we do increase these numbers, and as I say, we are very actively engaged in the discussions about trying to make sure that happens.
Thank you. And leading on from that, another workforce related question. So endoscopists, as you noted, will be crucial to how do we attract to the posts which can over time lose job satisfaction?
Yes, the workforce for endoscopy is a real concern. As we move away from flexible sigmoidoscopy to other techniques, then I hope that the people who've been trained to do that will be able to retrain. And again, there's money in the budget this year to help with retraining people who've been doing flexible sigmoidoscopy to doing full colonoscopies, which I hope will be attractive. And I think it's important that providers are thinking carefully about the mix of what people's job plans entail. And I think there are some people who, and it varies enormously from person to person, there are some people who really enjoy being incredibly good at just one thing, and there are other people who need more variety in their job plan, and that needs to be taken into account in the way that we set these up. The important thing is that we try to get the resource into the system for people to be able to have those job plans.
Thank you, Peter, and thank you to our delegates for putting in some great questions there. We really appreciate you joining us, Peter, as I say, especially at this time when everybody's so busy, and I know you're being pulled in all directions as well. And I'm really delighted we've also got Alice Simon here from the national team to talk about quality of life, so we'll hand over to her. Thanks very much.
Thank you.
Great, thanks so much for having me here today. I'm very pleased to come and talk to you about our new Cancer Quality of Life survey, and I'm especially pleased to come and talk to you this week when we've managed to launch the survey across England, with around 7,000 invites having gone out to breast, prostate and colorectal cancer patients this very week. So it's very timely. So today what I'm going to talk about is a little bit about why we have launched this survey and what are we doing, and then some of the kind of how it is working, a bit of the nuts and bolts of what we've been doing, covering both the pilot testing that we did and also then the current rollout that we're doing now and what our plans are in terms of a future rollout. And then finally, I'm going to talk a little bit more about information on how you personally could help us support the survey and its launch and the support and help that's available to patients. Next slide, please. So why are we doing this? This is actually one of our long-term plan ambitions, and I've just captured the quote from it there. And for those of you that have worked in cancer care for a while, you'll know that it also was in our Cancer Task Force recommendations. And the idea here is that we will start to look at quality of life as an outcome measure. So we'll be considering quality of life alongside things like survival, and really trying to measure quality of life in a systematic way so that we understand a bit more about what matters to patients and what happens to them over the longer term. And this really will set a different tone for us in terms of bigging up on the importance of quality of life outcomes. Patients have always understood that this is important, but we're trying to sort of recognise that in a more systematic way and use it to inform how we provide care and services. And patients tell us also that this is something that they're really interested in, and so it's definitely a tool that can kind of help to empower patients. And I think this is very much an action that goes to the heart of our NHS values in terms of wanting to put patients front and centre of what we're doing and improving lives and the provision of quality care. And it also brings together these ideas that have been around for quite some time about joining up our physical health with our mental health. So that's our motivation here. Next slide, please. As you might expect, we also have a number of patient representatives who've been helping us to shape this programme of work. And they've very much been telling us how important it is. And again, for many people, this won't come as a surprise, but that what patients tell us they really want is that we understand what matters to them. We look at the impact of their cancer on their quality of survival. And there are many ways in which we are looking at providing a more personalised care approach, but we also need to look at the impact that is having and understand where quality of life is improving or is slightly worse, and which groups it could be better or worse for, and is there anything we can do about it. So that's where we're coming from. It's been, next slide please. It's been a journey for us to get to this point where we are rolling out the survey. As you might expect, we've done quite an amount of pilot testing. So the remit being that we would monitor the longer term impact of cancer, and our response being that, well, to do that, we need to ask patients about their quality of life, and the best way to do that is to do a survey. But starting from scratch with a new survey, we've had to do a range of pilot testing to decide how to do that. So we did some pilot work with cancer alliances around the country, including the Northern Cancer Alliance, and with Joe McIntosh. So thank you very much for your ongoing support, Joe, for this programme of work. And what we did was we worked with the cancer alliances with specific trusts around the country, and we looked at a variety of different processes and methods to help us decide what to do. And that included quite a strong push around a digital data collection, so a survey that could collect data online, looking at things that you would expect around surveys, like you'll probably need a reminder, how frequently would you need to do that. Unlike our cancer patient experience survey, there was a discussion around whether this could be a locally run survey or whether it needed to be a centrally run survey. So we tried out that as a different method. We had an initial remit to look at breast, prostate and colorectal cancer patients, but we did also think that we should be looking to see whether we can broaden that remit into other cancer sites. And so we tested some kind of scaling up activities, particularly in groups like blood cancers, gynecological cancers, and head and neck cancers. And we looked at kind of timing of assessment. So we did various kind of single measurement points, or was it better to run the survey twice in the same people? And then when do you actually send people a survey? If we're trying to look at longer term impact, what is a kind of inclusive approach, but also hitting that slightly further out point in terms of not just looking at people who've been most recently diagnosed and capturing that immediate reaction to having a cancer diagnosis, but really in terms of people who've been living with it for some time and where are they up to with their quality of life. So having done a lot of that testing, our conclusion was actually that it is very difficult to run this in a devolved, localized way, and it does put quite a heavy burden on the system. So we have gone to a centralized model. We have had this push to digital, and we are still doing that, but we still think it's absolutely essential. There are paper questionnaires for people. We've been able to go ahead with nationwide coverage, and our plan is that eventually to include all people with cancer. We're using a single assessment point post-diagnosis, and that is 18 months post-diagnosis. And in terms of uptake, we've set an initial ambition for a 50% response rate. Next slide, please. So just looking in a bit more detail about what that criteria look like now. So we're in 3 cancers at the moment. In the first year, expecting around 70,000 invites to go out. In terms of what are the questions that we're asking, we're using 2 well-validated quality of life questionnaires, and I'll talk a bit more about those later. It's slightly different to other surveys in that this is a census approach, so it's not a sample like the patient experience survey in a 3-month window where everyone who had an episode of care gets an invite in those 3 months. It's actually a rolling programme, so each month, as people hit that 18-month post-diagnosis point, it triggers us to send out an invite to them. And we have put in an amount of work into developing a feedback system for patients, as this was one of the things that came out as being quite centrally important to people, that they'd like to see a sort of summary of their results, and I'm going to show what that might look like later. And we've also put in a range of different quality of access support in terms of making sure that there's access to translation and easy read information. There's a website, and there's a telephone and email support to help you fill in the questionnaire. Okay, next slide, please. This is just a visualization of actually how that process works. So we're running this survey as a joint programme with Public Health England. So we're working directly with the Cancer Registry, and they identify the patients that are eligible each month, and they send that list to a contracted supplier called Quality of Health. And the supplier then does the invite and response system, in that they check the patient list, get letters and an electronic survey invite sent out, get the responses back in, clean up the data for us. They send out the reminders, and then they return that data to the Cancer Registry, and the data is then linked in the Cancer Registry. So you get both the quality of life response, the sort of subjective report of how that person is doing, linked up to what has objectively happened to them from the data streams that are already held in the Cancer Registry. Okay, next slide, please. So I just wanted to say a little bit more about the questionnaires that are in use. So we haven't started from scratch here. We haven't made up questions ourselves. There are actually a number of different quality of life questionnaires that you could use that have been through a kind of psychometric testing. And the 2 questionnaires that we've ended up using are one which is quite well known. They both have long names that are not very easy, but the first one is EQ5D5L, and that really is a self-rated health questionnaire. It has 5 items, and it has a visual scale where you can rate your quality of life from 0 to 100. And that is a kind of more generic questionnaire that is in use across many different conditions in the NHS already. So we could ultimately get some comparisons between different conditions there as well. And it's also used in things like looking at economic benefit. It's used to create something called QALYs, to look at the kind of cost benefit of differences in quality of life. And then the second one is a cancer-specific questionnaire called the EORTC QLQC30, and this is a 30-item survey, which is more specific to cancer patients, and it looks at things like physical, emotional and social functioning, but also some of the key symptom items around things like pain and fatigue. Okay, next slide, please. And one of the useful things about using these validated questionnaires is that rather than reporting each item, each survey question in a single way, we can actually create some summary scores from them. And this is really useful in terms of when we're thinking about the remit, which was to systematically monitor outcomes, quality of life outcomes, that we get more of a kind of summary score from these questionnaires. And the way that they're designed, there are specific directions on how to calculate those scores. And so I've just given some examples here of how that works. Next slide, please. And then for us, how are we going to use that information? And this is all under development at the moment, in that it's a bit chicken and egg, in that we need a large amount of data in order to explore it properly and be definitive about which scores we're going to publish. But the outline plan is essentially that there'll be 3 different levels of reporting. And the first being a kind of national level type reporting, which would help to inform the cancer programme about where we should be focusing our attention, and looking quite broadly at differences between groups, whether that be between cancer type or treatment type, stage of disease, deprivation, gender, ethnicity, and where we see differences, try and explore those further. And engage with our stakeholders and consider what could we do to improve quality of life outcomes where we see disparities. At our sort of next level reporting, as we've gone for this census approach, we're hoping that we'll be able to keep drilling down further and further as the data set gets larger. And certainly working with Joe and the alliances in the pilot test, they were very keen that we would be able to supply data which was specific either to the NHS region, the Cancer Alliance, and even in some places at trust level where there are enough patients going through the bigger trusts, and that we might here use a slightly different approach with maybe some predefined cutoff scores, and that this would come through a more internal data reporting system like CancerStats 2 that we have already existing. And then finally, as I said right at the beginning, one of the important things that patients have been telling us they want is a summary of their report, which they could use as a kind of way of reflecting on what they've completed, and also identifying, you know, is there something that's been worrying me? Is it actually more important? And bringing it to the front of their mind, maybe using that as a prompt to discuss the quality of their quality of life with their healthcare professionals. Okay, next slide, please. So Joe specifically asked me to say something about what our pilot data indicated. And I have to say this data set is still under analysis at the moment, so this is very preliminary. And we had about 2,000 responses here to work with, so it is quite high level, but it did reassure us that the questionnaires are working the way that we expect, in that we could see that there were differences between different groups of people, so that this is maybe not especially surprising that quality of life outcomes are poorer for some groups, like those with later stage disease. We also found that women had slightly worse outcomes, and especially those with breast cancer, also older people and those living in more deprived areas. We then did a second comparison with the Health Survey for England data for the EQ5D self-rated health measure. And so when we compare cancer patients to people in the general population, we can see that, again, maybe not surprisingly, but it's important to be able to actually show this with the data, that cancer patients have poorer overall quality of life and higher levels of anxiety, and then more difficulty engaging with their usual activities in their day-to-day life. Okay, next slide, please. And then in terms of what the other end of the reporting, when I was describing to you that patients would like to have a summary report, this is a mock-up of what that summary report it might look like, and that is going through user testing at the moment. So really here we're trying to develop something that quite quickly communicates those summary scores to people And at the moment, we're looking at something using kind of RAG rating and describing what percentages mean and flagging an issue that you may want to talk about with a healthcare professional. And I'm pleased that this is developing quite well, and the initial feedback on it has been quite good. So fingers crossed we will get that out next year. Next slide, please. So in terms of what is happening with the rollout of this survey, we did our first kind of nationwide test in September, and that's now completed. And as I said at the start, we've now launched 100% across breast, prostate and colorectal cancer patients just this week. But we're not going to stop there, and we are, you know, this is really a kind of slow burn in that we're trying to build up the survey over time. And so from next year, we want to try and start including other cancer types and increase it to be available to everyone, so that we have a consistent measurement point for all people at 18 months post-diagnosis. We want to be pushing out this patient summary reports and finding a system that works really well to do that. And we should start to see some preliminary data coming through from the summer onwards. And then by October next year, to be confirmed, notwithstanding any further hiccups, that we will start to get regular data publications coming out to people. Just reflecting, next slide, please. Reflecting on that process test that we've run between September and December, we, as you might recall, I said that we'd set a kind of 50% response rate that we were looking for, and that was based around the pilot testing that we did in the 5 cancer alliances, and we've largely been able to replicate that with our new survey supplier. And the way that the system works is that you initially receive a letter which directs you to an online survey. And so our first response is always in these orange bars, which is the online response. And then 2 to 3 weeks later, you get a follow-up with the paper survey. And so the paper responses are slower to come in. But what is pleasing, if we look, say, at the September data, is that it's a pretty even split between online and paper responses now, and that's quite reassuring for that change towards that digital push. And also, I just wanted to mention that the helpline and the email trails that are coming through from patients, we're not getting a huge number of people with worries and concerns, and out of the 2,300 people we invited, we had a total of 54 people making contact. And also we can see how people are accessing the survey online. So generally, people are accessing that online survey in a multiple of different ways, on their phones, on desktops, through a QR code. So that online system is working quite well, and there's not too much, but it certainly is true that still those queries that we do get out of those 54, maybe a third of those are around people who would prefer the paper survey. So it's absolutely essential that we keep that in there. Okay, next slide, please. And then in terms of the kind of questions that have been coming through to my team at the Cancer Programme, I just thought I would touch on these in case that helped anyone. So quite commonly we get asked, well, do trusts need to run any additional information governance or data protection activities? And the answer to that is that no, there's no additional information governance requirements. The way that we're set up is that Public Health England are the data controllers for the survey, and through their setup with the Cancer Registry, they have various special dispensations in terms of contacting patients, and so we are already covered and under those legal permissions, and trusts don't need to do anything additional on top of that. The other question we get asked is about whether there are any status health checks before the survey goes out, and just to reassure you that that absolutely does take place, and our supplier Quality Health carries out a DBS check in the 24 hours before invitations are sent out and at the reminder point. And then the other query is around, quite rightly, around how are we managing people who make those contacts to the helpline, and particularly where patients are expressing any level of concern or distress. Well, this gets immediately notified to Public Health England, and Public Health England has a data liaison team who are making contact with the trust directly to notify them. and the trust is then contacting the patient and reporting back to that team about what the outcome of that was, so that we are checking that we're following through on all of those queries. Okay, next slide, please. Just in terms of a bit of a shout out and a call to arms, this year what we would really like support from everyone is in terms of raising awareness for the survey. So in year one, we're not going to be seeing a lot of data coming out, and the focus really has to be around getting the survey rolled out in a sensible way and in a way that encourages people to take part. Sorry, next slide. It would be ideal for us if when a patient talked to you about this, which they may well do, that you encourage people to take part, generally talk about the survey with other people, maybe look at whether people are going to be receptive and ready to receive results from the survey when they come, and generally be supportive of patients and be responding to their queries either by directing them to the helpline or to me and the national team. We've released, on the next slide, a range of supporting products to help cancer alliances and anyone within the NHS to talk about the quality of life survey, and these are all on our Future NHS Cancer Alliance workspace platform, and certainly Jo is well aware of all of these and can help people with that. And I've just also put down here, you can see the link to our website and to the telephone helpline in case you need it. And then next slide. Also here are the contacts for me and for my project manager Erin in the central team, and the email address at Quality Health. And that is it. So thank you very much, and I'll take any questions.
Hi, thank you again, Alice. Really appreciate that, and I think it's going to be a real challenge for us as a system to think about how we use the information from the Quality of Life survey and respond to it, and that'll be something we need to really think very carefully about going forward. Jo, do we have some questions there from delegates as well?
Yes, we do. Yeah, I suppose in part, Alice, you've answered this first question, but I will go through it in case there's anything extra you want to add. Will data from the Quality of Life survey differentiate between different patient groups in respect of health inequalities and understanding possible differences in quality of life for them? Okay, so the way that we'll be looking at this is by area level deprivation in one way, and we can also more broadly look at other markers in terms of socio-demographics, whether that be gender or ethnicity. So yes, we are able to look at differences between groups and try and detect where there are inequalities. And in respect of health inequalities and understanding, and so yes, and then relating that back to quality of life, and where we find those differences, we certainly would want to be asking more questions about what can we do about it, and potentially targeting our resource to make some changes there. Brilliant, thank you, Alice. The next question is, where does the additional workforce resource come from to do quality of life well? Okay, so in terms of what happens next, yes, so it's not an easy to answer question, but we obviously have a much wider programme of work around personalised care that is already going ahead, and we can see how these things might all link together in the end, whether that be through resources that are going into primary care around social prescribing, or cancer support workers in secondary care. So ideally, the results from this survey will just help to focus some of those activities. Thanks, Alice. And finally, the last question is, COVID has shown that we cannot rely on resources from charities for this work. How can quality of life metric and support be commissioned? Again, I think this relates back to the previous question, and
what we will do when we start to get the data through is that we will obviously keep all of that under review, and we will go through another stakeholder engagement round to discuss, what additional might be needed, or is it through the existing programmes of work such as the personalised care agenda, which is much as we did in the very early stages of working out how to run this survey, in that we're most likely to hold various kind of events, sort of stakeholder conference type, to assess what do people make of the results, and where do they think we need to be putting in energy and support.
That's great, thank you, Alison. Thanks to everyone who's contributed to the questions there as well. Really appreciate you joining us, Alison. I know you work closely with Joe on this, and it's great that we've been able to be part of this in the North East and North Cumbria as well. I'm going to hand over to Dan now to hear about the Rapid Diagnostic Centre work. Welcome, Dan. Thank you very much again for joining us this afternoon.
Good afternoon, everyone, and yeah, thank you very much for having me. I should probably start with a quick apology. I mean, it would be much better to have done the long train journey up to see you in person. One of the costs or benefits, depending on your perspective of me being at home, is that there's a small possibility that a toddler might invade my presentation at some point, at which point you will just have to forgive me while I deal with the source of noise. But thank you very much for having me. Really nice to have the opportunity to talk about rapid diagnostic centres. Can I have the next slide, please? It's very Chris Whitty kind of feeling. Good. So going to cover a few different things. I think I've got about 15-20 minutes of talking, and then I want to make sure we've got a good chunk of 5-10 minutes at the end for questions, because I'm sure there will be some. But first off, just for those who aren't so familiar with the NHS Cancer Programme, I'll run over kind of the broad sweep of what we do quickly, and where the RDCs sit within that, and particularly kind of how we think about earlier and faster diagnosis. I'll have a talk about where we actually are with the National RDC programme and the kind of broad sweep of that as well. And I'll talk about our plans for the future of rapid diagnostic centre delivery, and in particular we'll touch on the evaluation of rapid diagnostic centres, which is particularly critical. I've also just pulled out from our most recent evaluation to share with you a few notes about what we've seen, just so that everybody on the call is aware of what at least is reported back to us on what's going on in the Northern Cancer Alliance at the moment. So that's kind of broadly what we're going to cover. Next slide, please. So to start off with, I should also apologise, because looking at the formatting on this slide, something's gone slightly awry in the transfer. So I apologise if some of the diagrams and text don't quite match up. That looks slightly dubious at the top there. These are the kind of 5 core planks of the NHS Cancer Programme. So you've got it runs over early diagnosis and screening at the top. You've got faster diagnosis and access to diagnostics at the second there. Then you've got a sort of treatment plank. You've got personalised care and PSFU and the quality of life agenda that you've just been hearing about fits in that 4th plank. And then we've got that 5th plank, which is really about harnessing all of the innovation and the great work that's going on right across the healthcare and cancer community to deliver for patients. And as you can see, we have highlighted the faster part of this, and that's really where RDCs sit. So I just want to be it's always good being completely clear early on here. Yeah, this is for us about making sure that the people who need it get fast access to diagnostic tests, they can get their results quickly, and that whether they've got cancer or not, we're getting them that answer as quickly as possible. And I'll come back to that or not point a little bit later as well. I also just wanted to highlight here, really importantly, and this is something that one of the questions quite rightly highlighted in Alice's presentation on quality of life, that equitable is absolutely critical there. So when we're thinking about the development of RDCs and making sure that people have got fast access to diagnostic tests and their results, that health inequalities point and making sure that access is broad-based and equitable is absolutely critical. We know that one of the drivers that we have for later diagnosis is disparity in access to the right test, and that's something that we really want to address via this program as well. In terms of what RDCs are in essence, there are sort of, I suppose, two key elements. One is a streamlining of services, and one is and a kind of a developing better ways of running the diagnostic pathways that we already have to a large degree. And the other is about implementing this new referral route for patients experiencing non-specific symptoms. Often in the past they were called vague symptoms. We've tried to change the language around that because the symptoms themselves aren't vague, it's their meaning that might not be altogether clear. And there's long been a sense that patients might receive multiple referrals, so you get you might start with a lower GI referral, and then you get a colonoscopy and you have bowel cancer, you go back to the GP's not convinced, sends you for an upper GI referral, you get a gastroscopy, or don't have esophageal cancer, and it sort of rolls on, and eventually it turns out that you had a liver problem, whether or not it turns out to have been cancer. You've just had, the feeling from a patient perspective is that you've bounced around the system. The feeling from the perspective of the GP is that they're worried about their patient and unable to get them to the right place, and the feeling from the specialist who eventually has diagnosed this patient with potentially a serious condition is surely there's there was a better way to get this patient who's now potentially quite a way down the line, maybe their disease has progressed or something, maybe there's a better way of getting them to me. So those are the kind of two core elements of kind of why we've set up the RDCs, I suppose. So it's both that sort of the cancer pathway wide streamlining of services, but also that specific issue of the non-specific symptoms. Next slide, please. So here you go. Here's where the formatting's going to slightly come unstuck. So I will try and talk to maybe a bit more of the specifics on the slide than I was planning to, just to make sure that you can actually get all the info. So in terms of the National RDC programme, obviously the current COVID context has slightly changed exactly what we are expecting to be delivered this year across the board. But we do see, and the feedback that we've had from a lot of our colleagues in cancer alliances and trusts across the country, is that actually the rapid diagnostic centre model and all of the things that we are looking at for rapid diagnostic centres are absolutely the right things to be looking at to make our services sustainable with constrained capacity, potentially huge demand from people coming back into the system who haven't been diagnosed through over the last nine months or so, and therefore getting RDCs back up and running, back into development, and sort of accelerating that process again is absolutely a priority for recovery and restoration, and for getting those patients that we know haven't started treatment over the last 9 months into treatment as quickly as possible. Those of you who are familiar with rapid diagnostic centres will be aware, will have seen this diagram, which are the 7 principles for rapid diagnostic centres from the from the original specification from 2019, and in particular, I suppose, in the current context with COVID, those three things in the middle that have sort of been embossed, if you like, are the big ones that we're looking at. So timely referral, we know referral numbers took a big dip. They're now back up and running, but we know that to close the gap in terms of the number of patients who started treatment this year, we're probably going to need to run that at more than the usual number for some time. So identifying the right people to refer and making sure they're getting in quickly is absolutely critical. Symptom assessment, so triaging, prioritizing patients. We know that we need to get referrals back up, but we're under absolutely no illusions about the challenges we've got with capacity, particularly with the changes that need to be made to make services COVID safe. And so making sure that we are assessing patients, we are putting the right patients at the front of potentially quite long queues in some cases is absolutely critical, and arguably more critical now than it has ever been. And coordinated testing. Now, again, this is one of those where you may say, yes, always we want to be coordinated with our testing, but I suppose the key thing that I would focus on here is trying to organise the testing that we're doing into as few visits to hospital as possible. Now, we have a lot of economic and sort of activity and clinical data that suggests that the more actions that are happening on the same day for a patient, that has a huge impact on how quickly they get to a diagnosis. That might seem obvious, but it's the picture is quite stark, and obviously from an infection control perspective, the fewer times somebody is going out and coming back into a hospital or healthcare setting to get their tests, the better at the moment. So the imperative to do this is again heightened by the COVID-19 pandemic. Next slide, please. So in terms of where we are on delivery, the Cancer Alliance RDC plans have been signed off for this year. We did a sort of a replanning exercise as part of the phase 3 plans for the NHS after the first wave of the pandemic. Most Cancer Alliances, I have to say, have set out plans that are well above the minimum delivery requirements that we set out, which is fantastic. And essentially, for those who are not aware, the goal there was to build on the 1920 requirements, which were fairly modest because the requirement in 1920, because the situation was evolving throughout the year, was for work to really start in earnest from January on delivery. And we should build on those requirements and support COVID-19 recovery by delivering an RDC pathway for a challenge 2-week wait pathway with a focus on those pathways key to recovery. And we have seen in the plans that people have been coming back with that upper GI, lung and lower GI are the site-specific pathways that people are focusing on the most. And the reality is that we know that those are the 3 big volume pathways where we've seen the most significant disruption for slightly different reasons. I think upper GI and lower GI, the issue has primarily been challenges around endoscopy and concerns about infection control, and the volume that we're able to get through in those diagnostic pathways. And with lung, we've had a combination of that, and obviously there are additional concerns around infection control when one of your key symptoms is coughing, frankly, and also just in terms of getting the right patients into the pathway. I think some of the messaging has been challenging around getting people with potentially quite clear lung cancer symptoms. Those people would have been being told for the last 9 months to self-isolate and certainly not to go anywhere near a hospital. So there have been significant challenges around the lung pathway. But that's what we're seeing, and it's not unexpected. There's been a huge amount of sort of engagement work going on across Cancer Alliances and indeed with the national team. So we're seeing lots of work going on, as you might expect, with primary care networks and with provider trusts. We're also seeing a fair bit of work going on with independent health providers, and I think particularly in some areas that's quite a core part of the sort of community and primary care infrastructure. And also, encouragingly, we're seeing some crosswork with other networks, for example, mental health and other sort of, I was going to say tangentially related, but that's not quite the right word. But you understand what I mean. That they're non-core to cancer, but they're really important for many of the people going through these pathways and receiving a cancer diagnosis. In terms of the data that we've seen, we actually have October data now, but I wasn't able to update it in time, so I'm afraid you'll have to make do with September. But from September, we had 50 RDCs currently live and a number still in development and due to go live by the end of the financial year. Most Cancer Alliances have at least one non-site specific pathway live or planned, and by planned we mean sort of imminently to go live, and most are planning site-specific pathways. Many Cancer Alliances have gone well beyond what we asked for, basically, which is fantastic. During September, so we're currently collecting data on non-specific symptoms referrals. So we've seen 950 referrals on non-specific symptoms pathways. And we've had via that over 67 patients diagnosed with cancer with a 7% conversion rate. Some of these figures are a little bit rough around the edges because we're still at quite an early stage with this. The referral numbers are quite low, and essentially Cancer Alliances can't submit a number smaller than 7 to us for data for disclosure reasons. So the number of cancers will be slightly underestimated here, but it's in the right range. And you can see that actually, despite having non-specific symptoms, actually the chance of having cancer for patients referred on this pathway is actually pretty high. I've got some other sort of slightly anecdotal and very early data just to illustrate another core point. I said I was going to come back to the non-cancer side of things. So just across two Cancer Alliances, South East London and Greater Manchester. So in South East London, we've actually seen over 3,500 patients via the non-specific symptoms service, and their conversion rate to cancer has been about 10%, and about 30% of the patients have a serious non-cancer diagnosis. Now, to me, that number seems quite high, to be honest. And certainly in Greater Manchester, we've seen about a 7% cancer conversion rate and a non-cancer but serious diagnosis rate of about 11%, 10-11%, which seems more what I might have expected beforehand. But I guess the broad message here is this non-specific symptoms pathway is finding a lot of significant disease, and it's not just cancer, but although we are the NHS Cancer Programme and you are the Northern Cancer Alliance, of course, the sort of positive externalities of the work that we do on other conditions and making sure they're getting diagnosed appropriately is absolutely a critical part of this. And so when we're looking at what we're seeing, what we're delivering, the cancers that we're diagnosing, it's really important that we also look at that non-cancer element. And it's really important that as we're planning and developing these services, we're making sure that we don't just stop at ruling out cancer, and that we're making sure that we're getting to a diagnosis rapidly, and where there's serious disease to be investigated, we make sure that we're finding it. Next slide, please. Not going to spend too much time on this, but this is basically our sort of rough schematic for the future of national RDC delivery. So our national team priorities. So obviously we have, as our colleagues from the Alliance will be more than familiar with, we have our beloved planning process, and this is part of the sort of wider NHS operational delivery planning process that we will be running as we move towards phase 4 of the COVID response, which is, I believe, essentially everything from April next year. We're also developing this new, what we're calling an account management function, and that is basically to try and provide much more basically to make us more accessible to cancer alliances, and to try and get to try and have a more frequent touch point, a clearer sense of who you in the Cancer Alliance can go to progress these projects. And the third absolutely critical one that we really are starting to motor on now is the evaluation. Support for alliances is absolutely a core part of this. We want to continue to hold our collaboration events, to continue to share good practice via the workspace, to help alliances to work together, to share good practice and to work in a joined up fashion, and to make sure that we are providing good intelligence to you from across the country, but also that you're able to sort of provide it to us to inform the wider national policy. And then looking at the longer term priorities, we are starting now to look in earnest at, you know, what happens when we've rolled out and implemented the RDC model across the country. How do we make that sustainably commissioned for the future? How do we make sure that it aligns with the direction of travel on things like community diagnostic hubs, from the Mike Richards diagnostics review, and all of that side of things as well. So that's the kind of broad sweep of where we are. And you can't really see what it says in that navy blue box at the top, but it says experience of care embedded through the programme, and that's something that we're trying to do across all of our programmes and make sure that we've got that patient experience piece in on the ground floor, as it were. Next slide, please. So just a quick bit on the evaluation, because I want to move on to some questions if we have them. So we've commissioned Ipsos Mori in partnership with the York Health Economic Consortium and the Strategy Unit, which is a CSU, to undertake the evaluation of the process impacts and economic value of RDCs until 2024, which is the kind of first 5 years of the long-term plan. We've got 6 key themes. So we've got approaches to implementation, symptoms and diagnoses, so that, like, what are we actually picking up and whether it's cost effective, capacity, demand, resource utilisation and cost effectiveness, variation, so that's that equity of access point that I highlighted at the beginning, experience of care, absolutely critical to this, and making sure that that sense of bouncing around the system is gone, and then obviously potential harms. So we want to do more coordinated testing. There's obviously a risk if you're doing more tests on the same day. You're doing the kind of one-stop shop that you do things like over testing, and we need to keep a handle on that as well. We've just had, as it says at the bottom of this slide, the first quarterly report of the evaluation. We're currently kind of revising that and going through sign off, but that's been actually a really interesting piece of work to read. We can already see how the models are developing differently in different places. We've got models that are led by geriatricians and generalists in that sense. We've got specialist-led models that are more focused around GI, which is where most of those non-specific symptoms are coming into. We've got models that are led by MDTs, and then we've got models that are almost entirely primary care based in terms of being led by GPs. And it'll be really interesting to see across the country how those different models operate and what they deliver, and as we continue to iterate our work on RDCs, kind of the different outcomes that we're getting from those and sharing those back with cancer alliances so that you can develop your own models. Next slide, please. And indeed the last slide. I just wanted to, sorry, the title's gone over the text again in here. I just wanted to give, for those who perhaps are not so up to speed on the RDC programme across the Northern Cancer Alliance, this is what, at least what has been reported back to us, is happening in the NCA, and it may be slightly out of date, or I may have curtailed something to be slightly inaccurate. So please, those who know better, do let me know. But currently, Northern Cancer Alliance has implemented 2 non-specific symptom pathways, and there are plans in the works for site-specific symptom pathways. And the focus there has been really on that focus of greater engagement in primary care, getting those filter function tests going. So those are things like fit tests for suspected lower GI cancers, to make sure that we're prioritising effectively, raising awareness of cancer with the local population, and making sure that patients are able to get better access to primary care for initial assessment. So it's really been that kind of primary care focused model. I believe that currently they've been implemented in South Tyneside and Sunderland and in South Tees, and that those 2 sites take a slightly different approach. So you know, the South Tyneside and Sunderland, looking at if you've got the non-specific symptoms, you come in, you get a CT chest, abdo, pelvis. It's reviewed by a consultant gastroenterologist, and then there's an MDT to give wider advice on that. Whereas South Tees, they've taken more of a nurse triage-led role, led by a clinical nurse specialist. And this is, you know, these are, we've deliberately left the RDC model open to how a local area wants to tailor it to be most appropriate to their services and their local population. And it's really interesting to see within the patch the different models that are taking shape, and it will be interesting to see how they pan out. That's all I had to say. I've run a couple of minutes over. I'm very sorry, Joe and Sue, but I'm very happy to take any questions.
Thanks very much, Dan. I really appreciate that, and I certainly, you know, I'm obviously very involved in RDC work in our region, but it certainly made me think about how we pull people through from other services, and the work with mental health services as well is interesting, particularly when we think about lung cancer and other more common cancers. So that's a challenge for us, I think. Joe, have we got some questions there from delegates as well?
Yes, yeah, we have, Katie. So Dan, the first question is, what is the difference between RDC and optimal pathways?
So interesting. So I think the way that I would term this, so the optimal pathway is quite a sort of I mean, in many ways, it's quite operational. It's for those who aren't aware, we have 4 optimal pathways for, now I'm putting myself on the spot: lung, prostate, upper GI and lower GI cancers. And these are essentially blueprints to meet the 28-day faster diagnosis standard, or better indeed. So for lung cancer, that boils down to, you know, you should have a chest X-ray at this point, and then you should have a CT by this day, which is hot reported, and so on and so on and so on, all stacking up to diagnosis by, or ruling out of cancer indeed by day 28. The RDC, I think I see more as a broader service model than that. So it is those 7 principles. Now, many of those might be embodied in the time pathway. So, for example, coordinated testing point, timely diagnosis point, but some of them are either separate to that or need a separate focus to be fully implemented. So the kind of the patient support element, the prioritization of patients into the pathway element, the early identification of the right people to be on the pathway in the first place. So the RDC is the sort of diagnostic model that goes around that. But absolutely, you know, we can deliver those time pathways through an RDC, and that's absolutely kind of what we're looking to do, but they're not quite the same thing, if that makes sense. I hope that's clear.
Great, thanks, Dan. And finally, we've got, how will commissioning need to change for RDC compared to current 2-week wait pathways?
Now, this is an excellent question, and I think the honest answer at the moment is that I don't know, but I know it's a question that we need to answer rapidly, and it was one of the things that I highlighted on that slide of our priorities at the moment for the future of national RDC delivery. is to get into the long-term sustainable commissioning model. So at the moment, obviously, any additional costs, any setup costs, that sort of thing are being met from the Cancer Service Development Funding budget, and that's all well and good, but that is a transformation funding budget, and we need to put all of this on a sustainable footing for the future. And that probably does require us to work, well, it does require us to work out how those commissioning levers are going to work. At the moment, I don't know exactly how the changes that we're going to make in order to deliver that and make that possible. But it's certainly something that we need to have an answer to, and it's something that we're going to get an answer to over the course of the coming months, and certainly it's one of our high priorities for the next year or so.
And there's just finally a question popped up,
yep.
and I'm not sure whether this is actually for Dan or for Katie. Actually, is the Northern Cancer Alliance considering any primary care models for RDC?
So I can probably answer that, Joe, actually. So over in North Cumbria, the model they're looking at there is much more primary care based. But I think our challenge for all of our RDC work, looking at our pathways, is how we make transition through from primary care to secondary care as effective and as efficient as possible for patients in our cancer pathways. So we absolutely need to involve primary care in the work that we do, and make sure that work in primary care for RDC is resourced from the RDC budget as well. And I'm really interested in how we do that together. Right, well, I think thanks again very much to Dan and to Alice, and also to Peter again from the national team for joining us today. We really appreciate again all the time given by you and by our delegates joining us today when everyone's so busy, but it is really nice to just think that we can step outside of the busy work that we're doing, and just have time to share some of these thoughts and to think again about how we're going to move forward with the cancer agenda over the next year. I've just got a couple of slides just to sum up some things from us for the Northern Cancer Alliance, and while I just chat through those, if you want to put any questions for the Northern Cancer Alliance team in the question box, and we'll try and cover those as well. If we don't have time to do that, we'll do the same as we always do for our sessions, which is we will look at all of the questions and we'll respond to them, and make the responses available to people through our website or by communicating directly. So I'll just run through these couple of things, and I think actually the challenges that are on here have been covered really effectively by all of our speakers, and you know, Peter showed some really clear data around the impact on referrals, and the Northern Cancer Alliance has been hit in exactly the same way. So our referrals are recovering, and for breast cancer, we've got over 100% now of referrals compared to pre-COVID, but lung cancer referrals still stay a bit low and challenged, and this is one of the areas of work that we've been doing recently to try and address that particularly. One of the biggest challenges, I think, for us has been delivering against the long-term plan. Again, as Peter mentioned, about actually how do we do that, and particularly around rapid diagnostic pathways, and the way that funding was provided during the pandemic. While it was very effective and necessary to change to block contracts, it did slow up some of the work that we were trying to do, but we've been able to move that forward again, and it's great that we know that we can get on with some of this work now. Certainly one of the big successes for us in the Northern Cancer Alliance has been the fantastic engagement and collaboration of our clinicians, and that's been in things like developing the cancer coordination hubs, and also working together in the clinical drop-ins that were set up during the pandemic, and those were weekly initially for some of the tumour groups, and really was an opportunity to bring everybody together and try and make sure that we were addressing any variation across the region. FIT implementation of FIT was something that we've been working on anyway in the Cancer Alliance, and we were able to respond quite quickly, working together with primary care and secondary care to roll out access to FIT for the high risk patients as well, and we're still continuing to work to embed that across the region. And then the campaign work around encouraging people to still come into health services in the Help Us to Help You campaign, and then our local work on the lung cancer awareness campaign, which we really tried to target towards areas where we know there's higher incidence of lung cancer, and using a range of ways to reach people, including social media, but also through food banks and supermarkets as well, to reach people who are less digitally enabled. So, you know, I'm really proud of the work that we've been able to do over this time. The next slide actually we've just got again about continuing the recovery process. Again, I think these will be covered by our speakers around maintaining referral rates and reducing the backlog, and developing our capacity for the system. And I think with the around the community development of community diagnostic hubs as well as the RDC work, hopefully we'll synchronise to help us do that as well. The Rapid Diagnostic Centre work that Dan's touched on, there's, when we're thinking about all of our pathways now, we're trying to think about how does this fit with the RDC framework, and what are the things that need to happen for patients in those pathways for this to achieve an RDC for them. There's particularly work around the upper and lower GI pathways to look at how we can develop those particularly challenged pathways for us. And then around workforce, we have particular challenges, and there's very big pieces of work going on around breast and the oncology services. Oncology is challenged not just in medical and clinical oncologists, but the whole oncology workforce teams, and the nursing and therapy radiographers as well. So we really need to think very carefully as a region how we optimise and use the resources that we've got in the region. We think about health inequalities all the time in all of the strands of work that we do, and again, that's reflected in the targeted comms work that we've done, and working with primary care networks as well, and as we develop the RDCs. And colon capsule, Peter mentioned as well, which is now being, the pilot's being rolled out across the Northern Cancer Alliance, and we've been fortunate that we've been able to involve all the trusts in delivering that. And then the targeted lung health check work, we know that we want to do and get that up and running as quickly as possible, and that's been obviously particularly challenged by the issues with COVID and how that's affected our respiratory teams, and the capacity to actually get that work really moving. So I know that's been a sort of just a rapid run through of where we are from the Northern Cancer Alliance point of view, but again, just thank you to everybody who works across cancer services in the Northern Cancer Alliance, because this is how we are able to deliver our services and meet the needs of our patients. So I don't know if there's any questions, Joe, at all. Otherwise, we'll hand over to Andy just to close for us as well.
A couple of things, Katie. Unfortunately, Andy's had to leave to see to an urgent matter, so we're going to hand back to you for the close. But there is just one question. I suppose it's for me, really. How are we engaging with the public in any pathway work? So I suppose for us, in terms of more recently, it's, you know, the current circumstances that we find ourselves in has been more challenging, but we've continued to work very closely with our lay representatives, all who have had a presence and have an influence and input into all of our strategic group meetings. We've more recently restarted our public accountability forum meetings again, and in respect specifically of pathway work, we're working really closely with the national programme for RDCs, and we're in particular around the experiential measurements. So we've had input and been part of that work, and we will look to be part of the rollout there, but as well as look at how we locally measure experience and use the data that we get from that learning to drive improvement. And particularly our South Tees site, they've been doing that right from the very beginning and had some real great improvements based on the learning. So I think in summary, that's what we're doing at the moment. But I think the challenge back to ourselves is how do we find ways of working in the current climate with members of the public in terms of involvement, but by not excluding those people who, we've mentioned again already today that we will and have a lot of people who may be digitally challenged in terms of their access to resource. We've just got a couple more questions come through. Katie, if you're happy.
Jo, can I just go to Annie for a moment there as well?
Yeah, of course. Sorry, Annie.
Annie Wilson is one of our lay reps on the call as well.
Yeah,
and
I was just offering.
Annie, can we just hear from you as well about public involvement?
Yeah, just really to endorse what Jo said and maybe add a little bit more information, because it's not just the lay rep involvement. The Public Involvement Accountability Forum has met during the past few months. We've met twice, in fact, and we do have representatives there from patient groups. We also have representatives from the third sector. So we've got quite a wide reach as far as that group is concerned, and we've kept them up to date with the work that we're doing. We had to decide at the beginning how we were going to carry on involving people, and we've continued to look at that. And moving forward, we're thinking very seriously now about how you can involve people in the way that we were before, because we had a lot of people involved from their experience being able to contribute to the detail of pathways. My colleagues and I are all on the different pathways boards, so we do have that connectivity. And of course, we've done a lot of communication as well, which I have to say the Cancer Alliance team have been really fantastic at doing that.
Thanks, Annie. And there's another question coming, Katie. So we've got how many RDCs are planned for this year?
Right, so I think the one of the key things is to differentiate between RDC and the serious non-specific symptoms pathway. So the RDC model is how we will in the future be delivering all of our cancer pathways, our suspected cancer pathways, and one of the main starting points for RDC has been the serious non-specific symptoms pathway. So this year all of our trusts are now either delivering or developing their serious non-specific symptoms pathways within an RDC model. And at the same time, as I say, we've also challenged everybody to then think about whenever they do with any of their pathway work, how does that fit with the RDC model? And some of our pathways are further ahead with that than others. So particularly the use of teledermatology, I think, has transformed some of the skin pathways very close to being RDCs. There's specific work going on around the upper and lower GI models as well. So rather than say how many have we got, I would say that that's the sort of work that's happening across all of our pathways, but looking at developing the RDC models. I hope that answers the question. So Jo,
sorry, Katie, we've just got one more.
Very far away.
There was an earlier question, so yeah, about ACP roles and the workforce challenges to adopt them. Do we have any?
Well, I'm going to hand that question to Angela, who is our Secondary Care Clinical Director, who's on the call. So I'll just hand you over to her.
Yes. So hi. The ACP workforce certainly within cancer, certainly within oncology, is being headed by HEE, and we do have additional funding for that. We've just appointed a regional specialty advisor to develop a specialty curriculum. There isn't one nationally, so we're leading on developing that, and Nicola Story has recently been appointed to that regional specialty advisor post, and will work with consultant colleagues, nursing colleagues, radiographer colleagues around the region to develop that. So within the specific oncology setup, there is definitely support for ACPs. There's also, as you know, been support within for radiology and pathology for extending workforce. So we're working with HEE, and they have been very good at getting us funding. So we acknowledge, however, that if you appoint people into ACP posts, you often take those people that are already working in areas such as, for example, clinical nurse specialist roles, and that is another area of workforce that is hugely challenged. So the big programme for next year that we're now in the process of trying to develop with Health Education England locally is to develop some targeted workforce planning and support to increase the numbers and roles within the CNSs. So we acknowledge that when you train one, you have an impact on another. But I think we've got quite a good working relationship with HEE, and they're very cited on this, and there is national funding coming down. So I'm not saying it's going to be without its challenges, but we're aware of it. So I hope that to some extent answers the question.
Thank you, Angela. Is that everything, Joe? Are there any other questions? As we said before, we can always cover them at a later date and make the information available to people. So that's absolutely fine.
No more at all now, Katie, all done. Thank you.
Okay, thank you. Well, I'd just like to sum up again and say, you know, for a week in, you know, coming up to Christmas and at a time in the middle of our second wave of managing COVID, I think the opportunities for learning this week, we've been really pleased with the response we've had from people. We've had over 150 delegates over the week altogether, and thank you again to particularly to Joe McIntosh and to Sue Young, but also the rest of the Cancer Alliance team who've facilitated the event to manage to put on these 10 different sessions. So thank you again to everybody. Thank you for joining us for today, and I hope that was useful, and best wishes for the weeks ahead. Thanks very much.